Good morning, and I want to thank the RADCON organizers for giving me this opportunity to speak with you. So, in our institute, we have started liver transplant, and till now we have done 24 liver transplants, and next one is in the next week. So, that's why the importance of pre-transplant imaging is very important. So, in next 15 minutes, I'll discuss the role of imaging in pre-transplant cases. So I have no disclosure. So this is my outline. So I'll briefly introduce the topic, types of liver transplants, recipient evaluation, and donor evaluation. So orthotopic liver transplantation is the treatment of choice for end-stage hepatic disease, acute liver failure, and selective cases of SCC. So you have to, based on the image, we have to select the cases of SCC. So there are basically two types of liver transplants, cadaveric and living donor. So in our institute, we are doing, in most of the world also, living donor transplant is getting up because of the limited availability of the cadaveric transplants. And the cadaveric transplant may be whole liver transplant or split liver transplant. One liver we can transplant into 2 or more patients. And living donor liver transplants, there are different types. So this is the standard right hepatectomy. That means the right lobe of the lower liver is donated. That is the segment 5 to 8 are donated, and this is the standard liver transplant technique in adults. So in the pediatric case, because they need the small graft, we use the left lateral segments, segment 2 and 3. So this is for the pediatric patients. So when we need a little bit larger graft, then we use the left hemihepatectomy. So this right posterior segmentectomy, sectionectomy is for the complex portal or biliary anatomy, and sometimes when the remnant liver volume is inadequate, we do that. So this picture, Dr. Krishna also showed this picture. So before imaging, we should know that there are 4 cuts in the recipient liver and 4 anastomosis. So that is the portal vein division, bile duct, hepatic artery, and hepatic vein, and these are anastomosed. Usually the portal vein is anastomosed to the recipient's portal vein. Hepatic artery is anastomosed to the recipient hepatic artery. Hepatic vein is anastomosed to the IVC. And this hepatojejunostomy, or more often we do the choledostomy, that means CVD to CVD. So the pre-op imaging is required for both recipients as well as donors, and donor safety is the most. For recipient, we have to see the vascular anatomy, because during harvesting, so knowing the anatomy is important before harvesting, and we have to see whether the recipient can undergo transplant or not based on his conditions like hepatic or extrahepatic malignancies or other significant disease. In case of donors, we have to see the parenchymal abnormalities, whether he can donate or not. And then we have to, for the transplant planning, we have to see the vascular and biliary anatomy, and volumetry is very important. So role of imaging for the recipient is to exclude the intrahepatic and extrahepatic malignancies, so advanced malignancies. So in case of liver malignancy, we have to stage them. We have to rule out significant vascular invasion. And arterial anatomy is important. If there is accessory artery, then that has to be ligated separately. Venous anatomy is very important. Portal vein thrombosis, which we should exclude. So a small portal vein thrombosis can be intraoperatively, we do thrombectomy. But if there is extensive thrombus of the supramesenteric vein as well as the portal vein, then those patients we cannot do transplantation. And in case of recipients, we do imaging later, just before the transplant, because the tumor can progress if you do early imaging. So this is our last 23rd liver transplant recipient patient. So this patient has a small portal vein thrombosis. So this thrombus was removed intraoperatively, and patient did well after the transplant. So this type of patients, we cannot do the liver transplant when there is extensive thrombosis of the supramesenteric vein as well as the entire portal vein. So we don't get the, we don't do the transplant in this case. So there are many criteria for the selection of patient with hepatocellular carcinoma. So starting with the Milan criteria in 1996 and in 500 rule in 2019. So initially the Milan developed criteria of a single tumor less than or equal to 5 centimeter, or if there are multiple tumors, then there should be less than 3 number, all less than 3 centimeter. This was further, since this gave the very limited chance of transplantation, it was expanded. It was made single tumor 6.5 centimeter with each less than 4.5 when there are multiple, and total diameter of 8 centimeter. This was the University of California San Francisco criteria. But newer criteria, they have also included the alpha-fetoprotein also. And some criteria, they use the tumor differentiation along with the size for the selection of patients with hepatocellular carcinoma. So now we'll go to the living donor evaluation. So the donor safety is the most. So a living donor, so we should give the utmost importance to the living donor imaging. So in case of donor, the imaging has mainly 2 roles. One, to exclude the focal or diffuse liver disease, which exclude donation. And second is the planning of surgery by evaluating the vascular and biliary anatomy as well as liver volumetry. So in the liver parenchyma, we see if there is large benign lesion or any malignant lesion are contraindication for donation. Significant hepatic steatosis, usually the 30% or more is considered contraindication for transplantation. Vascular anatomy, arterial, portal venous and hepatic venous anatomies are important. Biliary anatomy, liver volumetry, and we should exclude significant extrahepatic disease or malignancy. So we are following this approach. There are different approaches. Some centers, especially in India, they are doing MRI first and CT after the MRI. So in our center, we do the CT first. So we acquire non-contrast and contrast CT in arterial, portal venous and venous phase images. And in the CT, we do the, we see the fatty, whether the liver is fatty or not. Then volumetric analysis, arterial, portal, venous anastomosis, this evaluation, and in exclusion of significant disease. And then we do the MRCP for biliary anatomy. We have not still started doing MR fat quantification. So I'm proposing this, I think we will start doing MR quantification, fat quantification, because MR fat quantification is better than CT fat quantification. And after some centers, they do MRI first. So they do the comprehensive MRI with volumetry and exclusion of other disease. And if the patient is suitable in MR, then only they do the CT scan, because CT we use radiation and CT contrast is more toxic than MR contrast. So in the donor, we should evaluate for the unexpected focal lesions and fatty liver. So if with each 1% increase in liver fat, the liver function decreases by 1%. And more than 30% hepatic steatosis is contraindication for donation. So there are different methods of assessment of fatty liver. So in the CT, we use the liver attenuation and liver attenuation index. And in MRI, MR gives more accurate fat quantification. The conventional MR image in and out phase of outphase MRI and chemical shift encoded MRI. So we can calculate the exact proton density fat fraction with MRI. So in CT, if the liver attenuation is less than 40 HU, or if the hepatic vessels have attenuation more than the liver parenchyma, or if the liver attenuation index is less than -10, these patients, they have significant hepatic steatosis and they could not donate the liver. And liver attenuation index is nothing but the difference of liver attenuation and the splenic attenuation. So this is one of the cases where there is significant hepatic steatosis. We see the vessels brighter than the parenchyma, and this is the technique how we calculate the liver attenuation index. So in the MRI, we can use the proton density fat fraction we had workshop few days back with US faculty, and in our system also we can measure liver fat. We can quantify the fat. Like this patient has 2% fat, while this patient has 40% fat. So we can exactly calculate. And they say this is better than the liver biopsy, because liver biopsy we take from the particular area, but in this technique we can calculate the entire liver fat quantity. So then we have to go to the vascular anatomy. So we commonly use the Mitchell classification for hepatic artery anatomy, and almost 55% they have the usual anatomy, that is the right and left hepatic arteries arising from the common hepatic artery. So this is the schematic diagram of the same. So while evaluating the arteries, we have to get the good MIP, maximum intensity projections of the arteries. So these are the axial coronal plane, and this is the 3D VRT image of the hepatic arteries. So the common hepatic artery arising from the celiac axis and dividing to the right and left hepatic artery. And we have, in case of right hemihepatectomy, we measure the length of the right hepatic artery after it gives the left hepatic artery, and we have to measure the diameter. Conventionally, the artery with length more than 1 centimeter and diameter more than 2 millimeter are harvested, but with improvement in microvascular anastomosis, even arteries less than 2 millimeter can be anastomosed. So identification of the segment 4 artery is very important, because this artery helps to significantly contributes for the regeneration of the remnant liver. So segment 4 arteries should be identified. Usually it arises from the left hepatic artery, but sometimes it can arise from the right hepatic artery, as in this case, this segment 4 artery has arisen from the right hepatic artery, and we have to divide the hepatic artery just after its origin. We should preserve it. So in the second case, we can see the segment 4 artery is arising from the right anterior segment branch. So this patient has difficulty because we have to preserve the segment 4 artery, and we need 2 anastomosis. So this type of patients usually we exclude. So replaced hepatic artery, when the hepatic artery arises, usually the left hepatic artery arises from the left gastric and right arises from the supramesenteric artery. So replaced hepatic artery is good for the surgeons because it has long length for anastomosis, and segment 4 artery does not arise from the replaced hepatic artery. That's why we should not, we are not worried much with this. So this is the normal portal vein anatomy. The portal vein divides into the left, right, and divides into the anterior and posterior. So Nakamura classification we use for the classification of the portal anatomy. This is the normal anatomy, trifurcation. This is the right anterior portal vein arises from the left portal vein, but extra hepatically. So this we can do the transplant, but in this case the right anterior arises from the left portal vein quite far after the into the liver parenchyma. This, and when there are multiple right branches from the left portal vein, so these are contraindications for the liver transplant. So we have to measure the length of the portal vein just right of the left portal vein and its diameter. So this is the trifurcation pattern, and this is the extrahepatic origin of right portal anterior portal vein from the left. So this still we can do the anastomosis. Then we have to see the hepatic veins. So usually the right hepatic vein is the dominant, and the vein which traverses IVC to the gallbladder fossa is considered the middle hepatic vein. And in standard right liver donation, the transection plane is just 1 centimeter right of the middle hepatic vein. So identification of the middle hepatic vein is very important. We have to measure the segment 5 and 8 branches from the middle hepatic vein. If they are larger than 3 millimeter, we have to anastomose separately because they can cause later congestion. So identification of the accessory hepatic veins is very important. And this is our next donation patient, donor patient. And if there is more than 4 centimeter distance between the hepatic venous confluence and this accessory hepatic veins, and then surgery will be more difficult. So MRCP is preferred for the biliary assessment. So we should measure the length of the right hepatic duct. So
Dr.
this is the normal anatomy.
Dr.
So I'll just
Sharma, we
finish.
need to wrap up.
So I'll just finish. So finally, we do the liver volumetry, and so two parameters are important. Graft to recipient body ratio, it should be more than 0.8%, and at least 30% liver should be remained for the donor. So we do CT volumetry in the venous phase images, and you calculate the total volume, right liver volume and left liver volume, and remnant liver volume, and coincident findings. So thank you.